Hey everyone, and welcome to the deep dive. As a general practitioner, you see a lot of different things, but today we're going to focus on one that pops up pretty frequently, I bet. We're talking about benign paroxysmal positional vertigo, BPPV for short.
It's one of those conditions that can really throw people for a loop, literally, and I think you'll find there's a lot more to it than meets the eye.
I'm intrigued already. But before we get into all the fascinating details, let's make sure everyone's on the same page. Could you give us a quick refresher on what exactly BPPV is? I know it has something to do with the inner ear, right?
You got it. It all starts in the vestibular system. That's our balance control center tucked away in the inner ear. So with BPPV, what happens is these tiny calcium crystals called otoconia, they break loose. They're supposed to be in a specific part of the inner ear called the utricle. But in BPPV, they drift into one of the semicircular canals.
Okay, so these little crystals go rogue. Why is that such a big deal?
Well, those canals are filled with fluid. And the movement of that fluid, it tells the brain how our head is moving. It helps us stay balanced. But when those loose otoconia get into the canals, they disrupt that fluid flow.
So it's like throwing a wrench in the works of our delicate balance system. No wonder people feel dizzy.
Exactly. The brain gets all these confused signals from the inner ear, and it thinks we're spinning or moving even though we're perfectly still. And that's what causes those sudden, often debilitating episodes of vertigo.
Okay, so we've got the basics down, but today we're going deeper. We're going to untangle the web of risk factors, the causes, the symptoms, diagnosis, treatment, the whole shebang. We'll even uncover some intriguing links to other health conditions.
Like that surprising link between BPPV and bone health, particularly osteoporosis.
Wait, bone loss and inner ear problems. Now, that's a connection I never would have made. I can't wait to hear more about that.
We'll definitely dive into that, but first let's talk about just how common BPPV is. Did you know that it affects about 2.4% of the population at some point in their lives? And that number, it skyrockets as we age. It's 7 times more common in people over 60.
Wow. So as our patients get older, it's definitely something we should be on the lookout for.
Yeah.
Are there any other groups that are particularly prone to BPPV?
Interestingly, women are 2 to 3 times more likely to experience BPPV than men. Combine that with the fact that it becomes more common with age, and you've got a population group that's especially susceptible to those rogue crystals.
Okay, so older women definitely at higher risk. But what is it that causes those crystals to go astray in the first place? Is it just wear and tear on the inner ear, or is there something else going on?
That's the million-dollar question.
Yeah.
You know, the one that's kept researchers busy for quite some time, and the truth is we don't have a definitive answer for every case. Sometimes BPPV just happens. We call that idiopathic. But there are some definite culprits. Head trauma is a big one. Even minor bumps or whiplash injuries can trigger it.
I guess we really do need to take those head knocks seriously, even the ones that seem minor at the time.
Absolutely. But trauma isn't the only suspect. We also see BPPV popping up in folks who have other inner ear conditions, like Meniere's disease or vestibular neuronitis.
So those conditions can set the stage for those crystals to break free. Any other less obvious potential culprits?
There are a few that might surprise you. For instance, there's growing evidence linking BPPV to giant cell arteritis. It's a vascular condition that affects the arteries.
Hold on, a vascular condition. How does that tie into inner ear crystals?
Researchers are looking into that, but one theory is that reduced blood flow to the inner ear, maybe due to GCA, might play a role. And that's not the only connection to vascular health. Studies have shown that conditions like migraine, hypertension, hyperlipidemia, and even stroke are more common in people with BPPV.
Wow, it's like a tangled web of connections.
Precisely. And here's where it gets even more intriguing. There's a link between BPPV and bone health, too. Studies have shown that people with BPPV often have lower bone density and higher rates of osteopenia and osteoporosis.
That's fascinating. It makes you wonder if bone loss could actually be providing the calcium for those otoconia crystals.
That's a really interesting theory, and one that definitely warrants more investigation. We'll be revisiting the connection between bone health and BPPV later in our deep dive.
Okay, so we've got vascular links, bone health connections, and of course all those inner ear suspects. But let's shift gears a bit from the theoretical to the practical. How does BPPV actually show up in our patients? What signs and symptoms should we be on the lookout for in our day-to-day practice?
The classic presentation of BPPV is recurrent brief episodes of vertigo, usually lasting less than a minute. And the key here is that these episodes are triggered by specific head movements.
So we're not talking about a constant dizziness. It's more like these sudden, short-lived spinning sensations brought on by certain actions.
Exactly. Common triggers include looking up, lying down, or getting up from bed, or even rolling over in bed.
I can see how that would be incredibly disruptive.
Absolutely. And it's important to remember that BPTV usually doesn't involve hearing loss or tinnitus. That helps distinguish it from other inner ear disorders.
So if a patient comes in complaining of both vertigo and hearing loss, BPPV might be less likely.
Right, it's not impossible, but other diagnoses should be considered. While nausea and vomiting can occur with BPPV, sustained vertigo is not typical.
Okay, that helps narrow things down.
Yeah.
So we've talked about symptoms and triggers, but how do we actually confirm a diagnosis of BPPV? I'm guessing it involves more than just asking the patient if they feel dizzy.
You're right. A careful history is essential, but the gold standard for diagnosing BPPV is a physical exam maneuver called the Dix-Hallpike test.
Ah, yes, the Dix-Hallpike.
Hey.
I've heard of it, but could you refresh my memory on the specifics? How exactly is it performed?
Sure, so you start with the patient sitting upright on the examination table. Then you turn their head 45 degrees to one side and quickly lie them back so their head hangs slightly off the edge of the table, still turned to that side.
Okay, so far so good. And what are we looking for while the patient's in this position?
You're observing their eye movements very carefully. You're looking for nystagmus.
Nystagmus. That's the involuntary rhythmic eye movement.
Yeah, that's it. And in posterior canal, BPPV, which is the most common type, you'll typically see an upward and torsional nystagmus, meaning the top of the eyes beat upward and slightly rotate toward the affected ear.
Okay, I'm picturing that in my mind. So the eyes drift upward and twist a bit.
Precisely. And here's the interesting part. When you bring the patient back up to a sitting position, the nystagmus reverses direction. It beats downward and slightly rotates away from the affected ear.
Now, that's pretty distinctive.
It is. And there's another characteristic to look for. The nystagmus should fatigue, meaning it decreases in intensity and duration each time you repeat the maneuver.
Okay, so we've got our Dix-Hallpike maneuver, and we're looking for that telltale nystagmus with its unique pattern and fatigability. But what about those cases where the patient has all the classic symptoms, but we don't see any visible nystagmus?
That's what we call subjective BPPV. And it can definitely be a head-scratcher. But here's the thing. Even without visible nystagmus, if the history is highly suggestive of BPPV treatment, may still be effective.
So we don't necessarily have to see the nystagmus to make a diagnosis and proceed with treatment.
Not always, but it is essential to rule out other potential causes, especially if the patient doesn't respond to treatment for BPPV.
Makes sense. Now, we've been focusing on posterior canal, BPPV, which I know is the most common type, but there are other variants that can affect the horizontal and anterior canals. How do those present differently?
With horizontal canal BPPV, the vertigo and nystagmus are triggered when the patient turns their head while lying down. The nystagmus can be either geotropic beating towards the ground or apogeotropic beating towards the upper ear.
Got it. Different head position, different nystagmus pattern. What about anterior canal BPPV?
Anterior canal BPPV is quite rare, but it can mimic posterior canal BPPV in terms of triggers. However, the nystagmus is downbeat and torsional, meaning the top of the eyes beat downward and rotate away from the affected ear.
So we're always paying close attention to the direction of that nystagmus.
Absolutely. The direction tells us which canal is affected, and that guides our treatment approach.
Speaking of treatment, let's move on to that now. From what I've read, BPPV sounds highly treatable. Is that right?
You are absolutely correct. BPPV is generally very responsive to treatment, specifically particle repositioning maneuvers.
Particle repositioning. So we're actually trying to physically move those rogue crystals back where they belong.
You got it. The goal is to guide the debris out of the semicircular canal and back into the utricle where it won't cause any more trouble.
That's incredible. So what kind of maneuvers are we talking about? I'm familiar with the Epley maneuver, but are there others?
The Epley maneuver is definitely one of the most well-known and effective techniques for posterior canal BPPV. It involves a series of specific head and body positions designed to move the debris through the canal and back into the utricle.
Okay, walk us through the steps of the Epley maneuver. I'm sure our listeners would appreciate a refresher.
Of course. You start with the patient sitting upright on the table, then have them turn their head 45 degrees toward the affected ear. Next, you quickly lie them down so their head is hanging off the edge of the table, still turned toward the affected ear.
Okay, got it. We're recreating that Dix-Hallpike position, but this time it's therapeutic, not diagnostic.
Exactly. You hold that position for about 30 seconds or until the vertigo and the nystagmus subside. Then you rotate the patient's head 90 degrees to the opposite side without raising it. They're now looking down at the floor with the opposite ear facing down.
Okay, 2 rotations down. What's next?
Now you have the patient roll onto their side so they're facing the floor, keeping their head turned at that 45-degree angle. They'll be looking toward the floor. Hold this position for another 30 seconds.
Almost there. What's the final step?
Slowly bring the patient back to a sitting position, keeping their head turned at that 45-degree angle. And that's the Epley maneuver.
Just a series of turns and tilts, but with such a powerful impact. Are there any other maneuvers for posterior canal BPPV?
The Semont maneuver is another option, and it's considered equally effective to the Epley. It involves a slightly different sequence of movements, but it also aims to dislodge the debris and return it to the utricle.
I'm sensing a theme here. It's all about strategic repositioning. But how effective are these maneuvers in practice? Do they really work?
The good news is yes, they do. Studies have shown that particle repositioning maneuvers like the Epley and Semont are highly effective for treating posterior canal BPPV. We're talking success rates as high as 85% with just a single treatment.
That's impressive. So most patients walk out of the office feeling much better.
In many cases, yes. And even if they don't experience complete resolution after the first try, the maneuvers can be repeated. There's a good chance subsequent treatments will be successful.
That's reassuring to know. Are there any patient groups that might need multiple treatments or have a tougher time with BPPV?
There are some factors that seem to influence treatment response. For example, patients with post-traumatic BPPV or those with BPPV stemming from vestibular neuronitis or Meniere's disease might require multiple treatment sessions compared to those with idiopathic BPPV.
So those underlying conditions can make things a bit trickier.
They can, but the important takeaway is that even in those cases, treatment is often successful. It might just take a little more persistence.
Okay, that's good to hear. Now let's talk about what happens after the maneuver. Is that it problem solved? Or are there things we need to tell our patients to do or avoid?
While most patients see significant improvement after the maneuver, it's not uncommon for them to experience some mild imbalance or dizziness for a few weeks.
So a bit of a recovery period is to be expected.
Exactly. It's usually self-limited, meaning it resolves on its own, but it's essential to counsel patients on this so they're not alarmed if they don't feel 100% right away.
Absolutely. We want to prepare them for what to expect. Now, what about activity restrictions? Should patients avoid certain head movements after a maneuver?
That's a good question, and there's actually been some debate about the usefulness of postural restrictions after treatment. Some studies have suggested that restricting head movement for a couple of days might reduce the chance of the crystals returning to the canal. However, other studies haven't found a clear benefit.
So the evidence is a bit mixed on that front.
It is. We don't typically recommend strict postural restrictions, but we do advise patients to be mindful of their movements and avoid quick, jarring head motions for a few days. It's more about using common sense than adhering to a rigid set of rules.
Makes sense. Now, one thing that really intrigued me was the idea of self-treatment maneuvers. Can patients really learn to treat their own BPPV at home?
They absolutely can. There are a few self-treatment exercises that have been developed based on the same principles as the in-office maneuvers. These are especially helpful for folks who experience frequent recurrences.
So they're like a DIY approach to BPPV treatment. What kind of exercises are we talking about?
There's the modified Epley maneuver, the modified Semont maneuver, and the Brandt-Daroff exercises. Each of these has its own sequence of movements, but the goal is always the same: to guide those pesky otoconia out of the semicircular canals.
I bet it's helpful for patients to have some control over their treatment, especially if BPPV is a recurring problem for them. But how effective are these self-treatment options compared to the in-office procedures?
Studies have shown that self-treatment can be quite effective, with success rates ranging from 65% to 90%. The modified Epley and Semont seem to be the most effective, while the Brandt-Daroff exercises might be a bit less so.
So while they're not a perfect replacement for in-office treatment, they can be a valuable tool, especially for those repeat offenders.
Precisely. It's like having a little toolkit to manage your BPPV at home. Of course, we always emphasize that patients should receive proper instruction and demonstration before attempting these maneuvers on their own.
Absolutely. We don't want anyone twisting themselves into a pretzel trying to self-treat. Now, before we wrap up this part of our deep dive, I wanted to touch on the other BPPV variants we mentioned earlier. Are there specific treatment maneuvers for horizontal and anterior canal BPPV?
You're right, we can't forget about those.
Oh.
Horizontal canal BPPV, for instance, often responds well to a maneuver known as the barbecue rotation or Lambert roll maneuver.
Barbecue rotation. That sounds intriguing. What's the idea behind that one?
It involves a series of head rotations while the patient is lying flat on their back. Imagine slowly rotating a piece of food on a barbecue spit. That's the basic motion.
I get the visual. And what about the anterior canal, that rarer variant?
The anterior canal can be a bit trickier. There's less consensus on the most effective maneuver, but modified versions of the Epley or Semont are often used.
So we might need to adapt our approach a bit for those cases.
Exactly. And if multiple canals are involved, things can get even more complex. But the good news is that even in those challenging cases, particle repositioning maneuvers can be tailored and adapted to address the specific problem.
It's like a customized approach to vertigo relief. And speaking of relief, what about medications? Do they play a role in BPPV treatment?
Generally, medications aren't the first-line treatment for BPPV, especially for those brief episodes of vertigo. Studies have shown that vestibular suppressants, which are sometimes used for other types of vertigo, don't significantly speed up symptom resolution in BPPV.
So those medications aren't the magic bullet for BPPV.
Not typically. However, they can be helpful as pre-medication for patients who experience severe nausea or discomfort during the repositioning maneuvers. Think of it as a way to make the treatment more tolerable for them.
That makes sense. So it's more about managing the side effects of the maneuver than directly treating the BPPV itself.
Exactly. Now, there's one medication that has shown some promise in reducing BPPV recurrence, and that's vitamin D.
Wait a minute, vitamin D. We're back to that bone health connection again.
It seems so. Some studies have suggested that vitamin D deficiency might increase the risk of BPPV recurrence, and supplementing vitamin D in deficient patients could help reduce those recurrences.
So checking vitamin D levels in patients with recurrent BPPV might be a good idea.
It's definitely worth considering, especially in older patients.
Welcome back to our deep dive into the world of BPPV. We've already covered a lot of ground, from those rogue inner ear crystals to those amazing repositioning maneuvers that can really make a difference.
It really is remarkable how much we can accomplish with just a few strategic head movements.
Yes. But we're not done yet. We still have so much to explore, including the long-term outlook for BPPV patients.
That's a really important point to consider. While those maneuvers are highly effective in the short term, we do know that BPPV has this tendency to come back. It's not always a one-and-done situation.
Oh no, so those pesky crystals can come back to haunt us even after successful treatment.
Unfortunately, yes. Those autoconia can become dislodged again even after we've successfully put them back in their place. But the good news is, those recurrences are usually treatable with the same maneuvers, whether it's in the office or with those self-treatment exercises we talked about.
So it becomes more about managing a recurring condition than completely curing it.
In many cases, yes. But even though it can be a chronic issue for some people, it's important to remember that BPPV is not life-threatening. And with proper management, patients can typically lead normal, active lives.
That's good to know. But what about the impact on quality of life? I mean, those vertigo episodes sound pretty disruptive, even if they are brief.
You're right, those episodes can significantly impact a person's daily activities, their work, their overall well-being. Just the fear of having a sudden vertigo episode can make people hesitant to engage in certain activities or even leave their homes.
So there's a psychological component to this as well.
Absolutely. The anxiety and fear that can come with BPPV can be really tough for some people. And as healthcare providers, we need to acknowledge and address those concerns, not just focus on the physical symptoms.
Okay, that's a good reminder to treat the whole person. Now, what about the long-term consequences of BPPV? Are there any risks associated with repeated episodes or prolonged untreated BPPV?
Well, while BPPV itself is benign, meaning it's not inherently dangerous, there are some potential long-term consequences we need to be mindful of. Recurrent vertigo episodes can increase the risk of falls, especially in older individuals.
That makes sense. Those sudden bouts of dizziness could easily lead to a loss of balance and a nasty fall.
Exactly. And falls can have serious consequences, especially for older folks who are more susceptible to fractures and head injuries. So managing BPPV effectively and reducing the frequency of those vertigo episodes is key in fall prevention.
Okay, that's an important message to relay to our patients. What about other long-term effects? Does untreated BPPV cause any permanent damage in the inner ear?
BPPV itself doesn't cause permanent damage to the inner ear structures. But there is some evidence suggesting that if BPPV goes untreated for a long time, it might lead to persistent dizziness or imbalance even after those acute vertigo episodes have resolved.
So it's like a lingering effect even after the crystals have settled down.
In some cases, yes. And this residual dizziness can be pretty frustrating for patients, impacting their daily lives and making them feel like they haven't fully recovered.
That sounds like a good reason to tackle DPPV promptly and effectively.
It is.
Now, we've talked about recurrence quite a bit. Are there any factors that make someone more likely to experience those repeat episodes of BPPV?
There are a few things that seem to increase the risk. Age is a big one. As we get older, those recurrences become more likely.
So those crystals are more prone to wandering as we age.
Seems that way. And just like with the initial development of BPPV, women are more susceptible to recurrences compared to men.
That gender difference pops up again. Any other risk factors to keep in mind?
Comorbidities can also play a role. For example, people with conditions like diabetes, hypertension, or hyperlipidemia seem to have higher rates of BPPV recurrence.
Interesting. So it's another reminder that we need to view BPPV in the context of the patient's overall health.
Exactly. And of course, a history of trauma vestibular neuronitis or Meniere's disease also increases the likelihood of BPPV coming back.
So those underlying causes can set the stage for repeated bouts of BPPV.
They can, and we can't forget about the potential role of vitamin D deficiency, which we talked about earlier. Correcting that deficiency might help reduce those pesky recurrences.
Right. So checking vitamin D levels and considering supplementation in deficient patients is a valuable strategy, especially for those with recurrent BPPV.
Absolutely. It's a simple intervention that can make a big difference in managing this condition long term.
Okay, that's a great point to highlight for our GP listeners. So we've covered the prognosis of BPPV, the risk of recurrence, and the potential long-term consequences. What's the main message you want to leave our audience with regarding the overall picture of BPPV?
I think the key takeaway is that while BPPV is often seen as a simple, self-limiting condition, it can actually have a pretty big impact on a person's life, both in the short and long term. It's important to recognize that it can recur to address any underlying health issues that might be contributing to it, and to provide comprehensive care that goes beyond just resolving those acute vertigo episodes.
Well said. We need to be attentive to the full scope of BPPV and its potential consequences, not just view it as a fleeting, albeit annoying problem.
Couldn't have put it better myself. Now, before we wrap up our deep dive into BPPV, I wanted to shift our focus to something that might seem unrelated at first glance. Children.
Children. We've been talking about older adults and age-related risk factors. How do children fit into the picture?
You're right, BPPV is much more common in older adults. But it's important to remember that children can also experience this condition, although it's far less frequent.
So it's not just a problem for grandma and grandpa.
Nope. While the exact prevalence in children is unclear, it's estimated to be much lower than in adults. However, it's crucial for us as general practitioners to be aware that BPPV can occur in younger patients and not automatically dismiss it as an age-related problem.
So we need to keep an open mind and consider BPPV as a possibility even in our younger patients.
Exactly. The good news is that the diagnostic and treatment approaches we've discussed for adults are generally applicable to children as well.
So those particle repositioning maneuvers can work their magic on kids too.
They can. Of course, we might need to modify our approach a bit based on the child's age and developmental stage. For instance, explaining the maneuver to a young child might require a little more creativity and patience.
I can imagine. And what about the causes of BPPV in children? Are they similar to what we see in adults?
There are some overlaps, but also some key differences. While head trauma is a common cause in both adults and children, other factors like inner ear infections or even congenital inner ear abnormalities might play a more prominent role in younger patients.
So that developmental aspect comes into play.
It does. And it highlights the importance of taking a thorough history and doing a careful examination to identify any potential underlying causes in children with BPPV.
All right, so we've got our diagnostic maneuvers, our treatment options, and even some insights into BPPV in children. Anything else we need to cover before we wrap up our deep dive?
I think we've touched on all the major points, but I do want to emphasize one final takeaway for our general practitioner listeners.
I'm all ears.
When it comes to BPPV, don't underestimate the power of patient education and reassurance. This condition can be quite alarming and disorienting, literally. Taking the time to explain the underlying cause, the benign nature of BPPV, and the effectiveness of treatment can go a long way in alleviating anxiety and helping patients feel empowered to manage their condition.
That's a great point. Knowledge is power, and in the case of BPPV, it can also be incredibly reassuring. So we equip our patients with the information they need to understand their condition, and we empower them to take an active role in their treatment and recovery.
Precisely. It's a collaborative approach that can lead to the best possible outcomes for our patients with BPPV.
Well said. I think we've covered just about everything there is to know about BPPV.
I think so too. It's been quite a deep dive.
It has. But before we wrap things up completely, let's take a moment to revisit that intriguing connection between BPPV and other health issues, especially as they relate to aging. We'll be back with part 3 of our deep dive in just a moment.
See you soon.
Welcome back to the deep dive. We've been on quite a journey exploring the ups and downs of BPPV, haven't we?
We have, and we've covered a lot of ground, but I think there are a few more important points that are really relevant for our GP listeners out there.
Okay, I'm all ears. What wisdom do you have to share?
Well, I think one thing we always need to remember is the patient's perspective.
Hmm.
BPPV, it can be a really disorienting experience, even frightening for some people.
I can imagine. It's easy for us as clinicians to get caught up in the diagnosis and the treatment, and we forget about the actual human experience of the condition.
Right. So taking the time to really listen to our patients, to validate their experiences, and to address those concerns, that's essential. Clear communication is so important. Explaining what causes BPPV, that it's not dangerous, and that treatment is usually very effective. That can really help reduce anxiety and make patients feel more empowered to manage their condition.
So it's all about that patient-centered approach, making sure our patients feel heard and understood and like they have the knowledge they need to navigate all of this.
Absolutely. And speaking of knowledge and education, I think it's worth circling back to the topic of prevention. We've talked about all the different treatments, but is there anything our patients can do to lower their risk of developing BPPV in the first place, or to at least reduce those recurrences?
That's a great question. I know we touched on vitamin D and how it might be helpful for preventing those repeat episodes, but are there any other lifestyle changes or preventative measures that our patients can benefit from?
Well, the research on preventing BPPV is still ongoing, but there are definitely a few things we can suggest. First and foremost, protecting the head from injury. As we talked about before, head trauma, even seemingly minor bumps or whiplash injuries, can be a big trigger for BPPV.
So all those safety measures like bike helmets and seat belts are even more important than we thought.
Exactly. We can't always prevent accidents, but we can definitely emphasize the importance of taking precautions.
Okay, head protection is key. Anything else we can recommend?
Another important thing is managing any underlying health conditions that might contribute to BPPV. Remember, we talked about those links to vascular disease, migraine, and bone health?
Right, so if we have a patient with BPPV who also has hypertension or diabetes or osteoporosis, we need to make sure those conditions are well managed.
Exactly. It's all about taking that holistic approach and addressing those interconnected health issues.
It's like creating a shield for our patients, reducing those vulnerabilities that might make them more susceptible to BPPV.
I like that. And while we can't guarantee that anyone will be completely BPPV-free, taking these steps can definitely make a difference.
Now, I wanted to shift gears a bit and talk about something that I know a lot of GPs struggle with. Referrals. When is it appropriate to refer a patient with BPPV to a specialist? It's a condition we often manage ourselves, but there are definitely times when a referral is necessary. What are your thoughts on this?
It's a great question, and it's one that doesn't always have an easy answer. Generally speaking, I think it's perfectly fine for GPs to diagnose and treat uncomplicated BPPV. We can handle those repositioning maneuvers, educate patients, and keep an eye on how they're doing.
Right, we have those skills in our GP toolkit.
Exactly. But there are some situations where it's a good idea to refer to an ENT or a neurologist.
What are some of those red flags that should make us think about a referral?
One big one is persistent or recurrent BPPV that just doesn't respond to those repositioning maneuvers. If we've tried the Epley or Semont a few times and the patient isn't getting better, it might be time to call in a specialist.
Okay, so treatment resistance is a key indicator. Anything else?
Another red flag is if the patient has atypical symptoms or signs. So for instance, if the vertigo lasts for hours or days, or if there's hearing loss or tinnitus or other neurological symptoms along with the BPPV, referral is definitely warranted.
So we're watching out for anything that deviates from that classic BPPV presentation. Any signs that something more might be going on.
Exactly. And of course, if we have any concerns about the patient's overall health or if they're really anxious about their BPPV, a referral for a more thorough evaluation and support can be helpful.
It's all about using our clinical judgment, considering each patient individually, and knowing when to reach out for help from our specialist colleagues.
Couldn't have said it better myself. Now, before we wrap up our BPPV deep dive, I want to come back to that intriguing connection between BPPV and bone health. It's a hot topic in research right now, and I think it has some really important implications for how we understand and manage this condition.
I'm glad you brought that up. It's one of those things that I've been really curious about. We talked about the potential link between bone loss and those autoconia crystals, but what else is there to this story?
Well, researchers are really digging into the role of vitamin D in BPPV. Some studies are showing that vitamin D deficiency might be a risk factor not only for developing BPPV, but also for those repeat episodes.
So it's not just about the calcium in the crystals. Vitamin D might be directly involved in the process.
That's what the research is suggesting, and that's led to some exciting research on whether vitamin D supplements could actually help people with BPPV.
So are we talking about prevention here? Could getting enough vitamin D actually lower the risk of developing BPPV in the first place?
That's what researchers are trying to figure out. And some early studies are showing promising results. It seems like vitamin D supplementation might lower the risk of BPPV, especially in older adults who are often low in vitamin D.
That's incredible. It could be a simple but powerful way to address a condition that affects so many people. What about for patients who already have BPPV? Could vitamin D help reduce those recurrences?
There's some evidence for that, too. Studies are showing that when BPPV patients who are low in vitamin D take supplements, their BPPV is less likely to come back.
Okay, so this is something we definitely need to be aware of. Checking vitamin D levels in our patients with BPPV and considering supplements for those who need them could really make a difference, both for prevention and management.
I completely agree. It's a simple and cost-effective intervention that could really improve our patients' lives.
And it highlights the importance of that holistic approach we've been talking about. We need to think beyond just those vertigo episodes and consider all the factors that might be at play.
Well said. And I think that brings us to a really important point. As general practitioners, we have this incredible opportunity to guide our patients toward a healthier lifestyle, one that supports their well-being in every way.
I agree. And that includes encouraging healthy habits that can benefit our BPPV patients too.
Absolutely. Things like regular exercise, a balanced diet with plenty of calcium and vitamin D, and being proactive about fall prevention, all of these things can contribute to a healthier inner ear.
It's all about empowering our patients to take charge of their health.
Exactly. And that's one of the things that makes our work so rewarding. We get to be a part of our patients' journey towards better health.
Well said. Well, I think we've covered just about everything there is to know about BPPV.
It's been a true deep dive. Thanks for joining us on this journey.
And to our listeners, remember, those tiny crystals might be small, but they can really pack a punch. Stay curious, stay informed, and keep up the great work caring for your patients with BPPV. And with that, we'll sign off from the deep dive.
Until next time.